A newborn's first breath, a beautiful moment. Yet sometimes the baby is silent, and sometimes the mother doesn't survive. The largest gulf between the developed and developing world is the maternal mortality rates. The chances of a woman dying in, for example, Sweden, due to pregnancy and labor complications is 1 in 30,000, while in sub-Saharan Africa, the chances are 1 in 16. And in some places in Africa, the chances of dying due to pregnancy and labor complications are 1 in 7. The impact on children, the family, and the community is devastating. One of the Millennium Development Goals, goal number 5, is to improve maternal health. The target is by the year 2015 to cut deaths associated with pregnancy and labor to a quarter of what they were in 1990. How are things going in sub-Saharan Africa? Are the countries on target for this goal? What does it look like at ground level? We travel to the Rift Valley in northern Tanzania, a rain shadow area. Here it hasn't rained for 7 years. There is no grass, the ground is dust, the cows are dying, the people are hungry. We visit the small village of Selela, which lies east of the Ngorongoro Conservation Park. The Maasai live on the outskirts of the village in cycles of huts surrounding bomas, the enclosures where the animals are kept at night. Maasai live in Kenya and Tanzania. Traditionally, they are nomadic herders traveling with their cattle following the rains, but they are now less mobile because they have lost a lot of their traditional grazing areas due to the formation of national parks and military zones, among other things. We meet Narkimunyaki and her husband Daniel. They have 4 children and she is pregnant again. She can't sleep at night, her legs are swollen, and she's worried. They have recently moved from Engaruka to Selela to escape witchcraft. A couple of days earlier, Daniel was forced to sell his last cow, and the situation now is very difficult.
Ni mzito. Kwa hiyo nikaona alipowahi kupata yani usiku anakaa tu halali.
What will happen to Narkimunyaki? She is expecting twins, and this pregnancy is more difficult than the last. She is far from the hospital and the family has no money. What is happening to help women in her situation survive giving birth? To get an overview of the situation in Africa, we attend a conference in Nairobi. This is the AMREN conference with midwives from all over Africa and the rest of the world. AMREN stands for African Midwife Research Network.
There are 350 participants.
This is a strong group of midwives using scientific methods to improve midwifery and improve the situation for mothers. We asked the midwives, why are the women dying?
A lot of women are still dying in our continent because of, needless causes.
It's 1 nurse to 60 patients in most of the health facilities that we see.
Female circumcision and maternal death is the worst.
Sepsis is the third main cause of deaths.
Even after delivery, the mother is still at risk of death. And that's where majority of the maternal deaths take place.
There are many reasons why the death rates are so high, reasons that are intertwined and difficult to separate. What is evident is that improvements are needed on many fronts to curb this catastrophe.
In African setting, you find that men are the head of the household, in most settings, over 90%. Being the head of the household, we are saying, makes decisions regarding even expenditure, makes decisions even where to seek health care. Women, they seek permission from their husbands of what decision to take, which family method, planning method to use. Even the sexual activities, they have to wait for the initiation from the husband.
You know, the percentage in men's, maybe the husbands coming to escort their mothers to antenatal clinic is very low, 0.1%, because maybe you won't even see sometimes that a mother who is very sick, pregnant, and the husband is not there with her, accompanying to the hospital. Maybe they will say, you go to the hospital and take care of the camels and the goats. And then the mother alone walks. Before she reaches the hospital, she collapses. Maybe she is due for her delivery, and you know if she bleeds after she delivers, she can go.
As far as they are going to remain poor, pregnant, then definitely they'll continue dying. Because they cannot make decisions for themselves, they are poor, they cannot make decisions because even if they make a decision to go to the hospital, they need money. They don't have the money, they have to borrow the money from somebody else who may not be willing to give the money. And therefore, that's it.
Narkimunyaki has, like most women in Africa, a lot of heavy responsibilities. Apart from looking after the children, shopping, and preparing food, she also has to collect firewood and repair their home. On top of that, she also has to fetch water. She has to walk 2 kilometers to where there is water and carry the 25 liters home again. Her pregnancy doesn't diminish her responsibilities, and these heavy tasks pose a serious risk to her in this late stage of her pregnancy. But in some places, things are improving, and men see themselves as an integral part of pregnancy.
Nyumbani tu ni kama nyumbani hivi ananijali chakula, nguo, anambia nataka kitu fulani ananipa. Mavazi, naambia maji kama ninaweza kuchota mwenyewe na nachota. Au yeye mwenyewe kama hajaenda kazini, kwa maana ni mtu kazini. Kama yuko kazini ndio hivyo. Lakini nikiwa mzima hivi, yani siumwi. Mume wangu ananijali. Sio kwa kuumwa, sio kwa kuumwa.
we visit Ngarenaro Hospital in Arusha, where a doctor and a midwife are giving pregnant women antenatal advice about how to ensure a safe pregnancy. As expected, there are no men, with one exception, and he and his wife are given priority to see the midwife. That is one incentive, to engage men more in their partners' pregnancies. The antenatal checkups are thorough. Besides the physical checkup, the pregnant woman gets her blood tested and HIV status checked. She is also given iron tablets, malaria prophylaxis, and a coupon for a mosquito net. All these measures help to improve the chance of mother and baby surviving. In most sub-Saharan African countries, women are good at attending antenatal checkups, but more than half choose to give birth outside the medical setting.
We need to shift our focus and involve men. The problem is we're not involving men when we are discussing about maternal and reproductive issues. So we leave them out and we expect the mother alone to make a decision, yet has very minimum ability because of socioeconomic status.
Baba anajiandaa kwa mipango yote ya uzazi na mtoto.
Maripala Lepelo is pregnant for the first time. She has walked for 4 hours to reach the Selela clinic for an antenatal checkup. Now it is a 4-hour walk back home again. The lack of transportation creates a lot of problems. And walking for hours is impossible when a woman is in labor. Once a month, it's market day in Mtwambu. Women use the opportunity to get a ride into town to visit the health center. Felix Sanga is the doctor here. His patients come from up to 100 kilometers away.
I started my career in a more remote area more than this. I worked somewhere where I have to walk for more than 40 kilometers going to my working station from the main road. But I worked there about 8 years, peacefully and very successfully.
And with poor roads and fewer vehicles, getting to the clinic can be a major challenge. Selela, where Narkimunyaki and Daniel live, has a local health clinic, but it is 45 kilometers from Dr. Sanga's health center. And sometimes that distance can be fatal. As in the case of Chagama Juma Rajabu, who is himself a health worker in Selela. But even being a health worker yourself is no guarantee. His wife gave birth to a healthy boy. But there was a problem. The placenta was retained and she was bleeding severely. She needed to get to a hospital fast.
Everywhere I'm going to try to search up to get the transport. I haven't. And then after 2 hours, 3 hours, you get in the bad car or staying on here. His bad car is a broken car. He's going slow. He's dropping down to open the cabinet to check the fuel, to check no braking, no anything. But he's going slowly, and 1 kilometer, 2 kilometer, he stand. 2 kilometer, 5 kilometer, he stand. He taking the water, he's on to cool.
But at Felix Sanka's clinic, there is an ambulance. So why didn't he send the ambulance to Selela to pick up Chagama's wife?
Because this car, it is modern, it's very low setted, and it cannot go in rough roads like the one to Selela or to Engaruka. We cannot reach them there.
I'm using the 3 hours to rush at the health center. 45 kilometers, 3 hours. But taking the car, good car, is already to taking the 30 minutes is enough.
So they arrived here too late because I sent this car towards where they had been, but we didn't reach them because the road becomes very rough. She died, unfortunately.
If only health centers at Selela and Engaruka have the car, no problems. My wife is already alive.
The appropriate car for this area, it should have been a 4 drive, which can go everywhere. Not this. This is it's luxurious, more luxurious.
It's not my wife only. There is many people who die because they are missing the transport on healthy facilities.
It is not only a problem for patients to get to the clinic. It can be a major problem for the medical staff to get to the patients as well. Engaruka lies another 50 kilometers away from the Mtwambu clinic. Irimina Ntwanga has worked 10 years in Engaruka.
Kwa kweli hali ni ngumu. Kwa mfano unaweza ukakuta kuna mama ameshindwa kujifungua. Unaenda unamwangalia ameshakaa masaa mengi sana, inatakiwa asafirishwe. Unakuta hamna usafiri. Inabidi ujaribu kumsaidia hivyo hivyo. Kungetokea hata mfadhili akatuletea usafiri. Au hata tungekuwa na mawasiliano basi, kuwe na ambulance labda Selela au Mtwambu. Mimi naona tuende. Pia kuna tatizo lingine moja ambalo pia hilo yani linanisumbua sana. Kwa mfano njia zetu jinsi zilivyo hazipitiki kwa baiskeli. Kweli baiskeli ninao lakini uwaga kuna sehemu zingine nashindwa. Sasa unakuja kuambiwa kuna mama ameshindwa kujifungua, tumehangaika naye tangia jana na yani usafiri jinsi ya kumbeba mpaka hapa haiwezekani. Pia kungekuwa na pikipiki ingerahisisha zaidi. Kwa sababu mara nyingine nawaambia tu kama wanaweza wanaweka pikipiki ya mtu mafuta na pelekwa unaenda mwenyewe. Kwa hiyo namuwai yule mama kwenda kumsaidia japokuwa unakuta sehemu zingine ni mbali.
Narkimunyaki and Daniel face another problem. They need 250,000 shillings, which is about $180 to hire a car to get to town if the labor gets complicated. This amount is way beyond their budget.
40 tu ambaye kuna ng'ombe ambaye nimeuza juzi, nikaa ndio nazungusha kwa biashara kidogo na watoto wapate chakula, matumizi, na kama nimepata mgonjwa nampeleka hospitali. Nilikuwa nayo 40 tu ili kwa ajili ya matumizi. Bado sijaonana kwa sababu nilikuja jana jioni. Ikawa daktari alikuja asubuhi kwamba kuna wageni ambao watakuja. Kwa hiyo mimi nilikaa kwa ajili ya wageni ambao wanakuja hapa nyumbani.
Beside the problem of bad roads, bad cars, and well-meant gifts is the problem of communication. In Engaruka, there is a tree that one could climb to make a phone call. Now, since there has been a change in operators, this doesn't work anymore. And in case of an emergency, there is no way of communicating with the outside world.
Hata hizi radio call tu zikiimarishwa, kwa mfano kipindi cha nyuma, radio call hii tulikuwa tunawasiliana na mtu ambu. Kwa hiyo kwa mfano mtu ambu kama kuna ambulance na tuna radio call, ina maana nikipata tatizo naweza nikaita ambulance ikawahi kutoka mtu ambu.
When we asked what their biggest wish for improvement of their job would be, the healthcare workers all answered.
Staffing?
Staff.
More nurses.
Like when I used to work in labor and delivery unit, I never used to sit down. My thinking was that if something goes wrong with a woman and she goes into trouble, she loses her baby or she dies, how will I deal with it in my life?
You already know what will happen if a midwife is overstretched and overworked. The probability that she will not give what you call quality care. And quality care, I mean either professional skills, communication skills, intellectual skills are very high. And that alone is a good recipe to tell a mother not to come back.
What we see the proportion of nurses to the patients, and that of course includes even the mothers, is 1 nurse to 60 patients in most of the health facilities that we see. Most of the nurses are taking care of more people than they are able to give quality care to. And I think that one is also overburdening the nursing profession.
It is a problem. Maybe if at all the government will improve, maybe some bonuses for those who are working in remote areas. If at all this can be given, maybe those who are in urban settings now, they will move to villages. Maybe they think that here you cannot make life, but here, life it is anywhere you choose to work.
Not only are the African midwives stressed and overworked, they are also poorly paid. In Kenya, a nurse on diploma level, which combines both nursing and midwifery, gets the equivalent of $60 per month. This is one of the reasons many apply for jobs outside Africa. The most popular countries to work in are the UK and the United States.
The attraction in the US, particularly, the pay is much better. They're getting about $5,000 per month. That's a huge difference. Most of them don't come back. And if anything, quite a number of them would be much more pleased to get the green card and continue staying in the US, because through that kind of stay, they're able also to support their relatives back in the country and also invest in other areas in the country. Most of them have gone through undergraduate program. And these are the cream of the nurses who are supposed to be managing the nursing profession in Kenya.
And they face other problems besides the stress and bad pay.
Being a midwife is very risky. You deal with blood and blood products every now and then. Mothers, when they deliver, they bleed. There has been an estimate, it's not really official, looking at the prevalence of HIV in Kenya and probably extrapolating that to the nursing profession, and they think it's about 25%. So I think they are at a higher risk in the health profession.
Sasa, mimi hapa nimeandika karatu, lakini hata ukienda, we miss most of necessary supplies. Sometimes you may order a drug, you wait for maybe more than 2-3 months to receive it. Maybe you ordered while you had very little or no stock at all. So this makes us work in a bit difficult environment.
Kuna vifaa vingine ambavyo tunatumia, kwa mfano mikasi ya kukata kitovu. Yaani hatuna delivery kit. Kwa hiyo kwa sababu hamna delivery kit, ina maana mikasi ile ambayo tunaitumia kule kwenye dressing, ndio hiyo mwisho wa kazi ukimaliza unaiandaa vizuri, inakuwa sterile, unaiweka tayari. Hii delivery bed yetu ina Macintosh moja tu. Kwa hiyo kama ina maana ukipata dharura wa mama wawili wakaja kwa wakati mmoja, inakuwa ni shida sana. Kwa hiyo hapa kuna Macintosh moja ambayo unatumia kwa mama akishamaliza basi unaidecontaminate alafu unatumia tena kwa wakati mwingine.
If a woman goes to a facility, then she reaches the facility, but then probably the health workers are not sufficient in terms of numbers or even qualification in terms of the skills, or even sometimes the resources are not there. For example, a woman has started bleeding from wherever she's coming from. Then she reaches a facility, maybe there is no blood. She needs blood transfusion, there is no blood. So it is just a cycle of many problems.
Sepsis is the third main cause of deaths of mothers during labor or after or during the whole process of birth and related complications. I looked at 5 areas, of which one of them was hand hygiene. We realized that only about 20% did it and did it correctly, which is not a good thing, because in infections, there's no room for mistakes. You have to do it the right way. The instruments are supposed to be submerged, example, but some of them are not submerged. You find a lot of it is heaped and some of it is left hanging outside, and definitely the whole process is rendered useless because of such practices. And you find that where there is supposed to be a tap, okay, maybe after 2 or 3 beds in an ideal situation, maybe there was one in a ward which was having running water. So you find this is also cumbersome for somebody to move from one end to go up to the other end to wash hands, just to come and do another procedure, which you found the administration needed to take up, even if not to have the ideal scenario, but at least have a few more to be able to meet the basic requirements. It's a major issue that really needs to be addressed. If we can play our part in terms of improving on infection prevention practices, then definitely we would reduce significantly the mortalities associated with deaths.
We forgot one thing, or forget one thing, that even after delivery, the mother is still at risk of death. And that's where majority of the maternal deaths take place. Yeah? About 60% of maternal deaths occur after delivery, not before delivery. So you see, we have been talking more of what is not really the issue and leaving what is really the issue. And usually the ones which come in the postnatal period are emergency, because we are talking of the postpartum hemorrhage, we are talking about the postpartum eclampsia, we are talking about septicemia, bad septicemia, which will kill people. Those who delivered in the homes, they should be brought in the hospital to be assessed or examined within 48 hours of delivery. Then we again expect them to come back within 2 weeks, then again 6 weeks, and finally 6 months. That's what we are calling the 4 visits of postnatal care. We do not have community health service providers going door to door, finding out how the mothers are doing their babies. And what happens? They go back to their houses, we have no track of them. They might not have the funds to come back to the hospital if they get a problem. And at the end of it, we are not sure whether they are not dying in their houses.
In Africa, there are many women working as traditional birth attendants, TBAs, and there are also very many women who, despite the risks, prefer being delivered by them. In Engaruka, we meet a number of TBAs. Nosokito Rwako is a TBA and has been working for more than 10 years, and she delivers about 5 babies a month.
Anatongo, hata ya ng'ombe hata bela. Kutengeneza ile mtoto tumboni. Si unaweka mafuta alafu unapeleka hivi hata unaona ambaye analala hivi au hivi unajua tu. Kama karibu atoke au bado kidogo unajua tu ukishika kwa mkono. Si unaleta kujipaka mafuta ili kuangalia kama iko mbali au iko karibu ingize ndani, si unajua. Na kapo mpaka jifungua. Napokea mtoto alafu kwa nguo, alafu mkate ile nyingi, namtolea tena ile lakini kondo. namtolea, anakaa, namuosha, alafu nampigia chai basi.
Kwa sababu kuna wengine wanatoa sheria kabisa, labda yuko ndani ya boma hilo, na boma za hapa zina nyumba nyingi. Unaweza ukakuta kaya moja ina nyumba, yani boma moja lina kaya karibia 5. Sasa yule bibi anatoa sheria kabisa kwamba haruhusiwi mtu yoyote wa boma hii kwenda kujifungulia hospitalini.
A Maasai woman going to deliver in the hospital. Some of them think that, oh, this woman is hiding something. Maybe she has been sexually very active, so she have infection, she infected even the child. So going there, she's going to hide something from us.
In the case of Narkimunyaki, it is her father who wants her to give birth with the traditional birth attendants, despite the risks of her twin pregnancy.
Nasikia unampeleka mama hospitali. Na mimi sikupenda upeleke ajifungue hospitali. Sasa nikamueleza hivyo. Basi sasa yeye akaniambia inabidi tu mwache akae. Paka akamwambia mtoto wake, sasa mtoto wangu mimi nakwambia kaeni nyumbani.
Against her father's wishes, Narkimunyaki decides to visit the clinic in Selela, accompanied by Daniel. She is already showing signs of pre-eclampsia.
Kwamba kuna wataalamu ambao wamekuja pale nyumbani na wamekuja kusema nao pia nendeni mpelekeni nani mwende hospitali kule kwenye huduma kubwa. Ndio ananiambia tumwambie nyinyi. Na mimi nikaendelea kumwambia, hata hivyo nimeshamwambia na nini nesi pale kwamba nitamueleza.
The TBAs are skilled and competent during a normal birth. However, when there are complications, they often don't have the necessary knowledge and equipment to save a woman's life. In some places, they are receiving training to detect complications early, so they can refer the woman to the necessary medical facility.
Pata elimu kwamba yule mama nikisha muona kwamba dalili zile za hatari, kuna dalili za hatari ambazo vidokezo vya hatari ambavyo nimefundishwa kwa mama mjamzito. Nikishaanza kuona vile vidokezo vya hatari, inanibidi yule mama nimkimbize haraka sana hospitalini, kumwambia awahi hospitalini kwenye kituo cha afya ili akapate huduma zinazostahili.
Kabla baadaye ya kujifungua ndio yeye anageuka.
But she does see symptoms that she has never seen before.
Ambayo mdomo wao ndio si nzuri na anaumwa mdomo.
Na kwa upande wa magonjwa kama vile VVU, ukimwi, sana sasa hivi tunapewa gloves. Unaenda pale hospitalini unapewa gloves. Kwa hiyo tunavozalisha tuzalishi tena mikono mitupu, tunavaa ile mipira alafu unamzalisha ili usipate maambukizi.
There are many reasons why women prefer TBAs.
Kweli inachangia sana kwa sababu wale wamama pia hapendi kukaa hapa, labda analia anapiga kelele hapa na hapo nje, wagonjwa wamekaa wanamsikiliza, au unafungua mlango pale unatoka mama yuko hapa anaona kama yani kwa kweli hawapendi kabisa, lakini basi kwa sababu ni shida wanakuja tu, lakini hawapendi. Ni kitu yani hicho kitu kinachangia sana.
Mimi ninachoona labda kwa vile pale kwa mama, kwa ule mkunga, yule mama anapata madekezo makubwa kwa sababu hospitalini ukijifungua uweze kumuita nesi umwambie nishike hapa au nifanye hivi, lakini pale nyumbani unavoumwa na ule uchungu, yule mama anaweza kukusaidia mambo mengi. Unaweza ukasikia kiuno kinauma akaja akakukanda, unaweza ukasikia labda hali hii, yule mama akawa anakubembeleza. Sasa kule hospitalini uweze kubembelezwa na mwenye kukandwa, nesi ana ule muda kuja kukanda mgongo kufanya nini. Ni kwamba yeye ameshajua kwamba amekupima, anajua kwamba kichwa cha mtoto kimesha karibia au bado masaa fulani, labda kuna vipimo atakavyovipima sentimita, anajua kwamba bado sentimita kadhaa za kutoka ule mtoto, kwa ajili yeye ameshapata mafunzo. Kwa hiyo sasa anajua kwamba hizi sentimita mpaka muda fulani itakuwa mtoto tayari. Kwa hiyo anaweza kuacha mradi
soma na ndo wakunga ambao watu wanawaamini sana. Wale hata ukiitwa ukienda hataki kusogea pale mahali alipokaa. Anataka uzalishe, lakini anaona ukishapokea tu mtoto utachukua kile kitu anachopewa, kwa hiyo hawapendi.
Many women fear to come to the institution. At some institutions, they are supposed to bring gloves, cord clamp, baby clothes. So the bill is too high for an ordinary woman to come and deliver at the hospital. So when they look at the expenditure, they would rather deliver at home, even if the environment is not safe, just because it's less expensive than in the hospital.
She knows once she has her baby delivered, the placenta will be delivered, and the placenta will be thrown like any other rubbish in a common, a bucket. You'll be thrown in a bucket, and to that community, that placenta is a sacred part of her, and should be taken with all the seriousness it is. Not just throw it like a rotten piece of thing.
The TBAs have a limited knowledge of modern techniques, but as they have more and more contact with clinics, there is an exchange of experiences and ideas between the two worlds.
We now have what we call the community midwifery strategy, whereby we are using the retired midwives and the people out of employment and the non-employed, and we encourage them to serve in their community. And what we are doing is we are equipping them with equipment and attaching them to the nearest health facility so that they can have those equipment sterilized. So ideally, it's like trying to replace the traditional birth attendant role, because the TBA role has now been changed. We now have a policy that defines that the traditional birth attendant's role is now more of referring and like advocating for the importance of facility delivery. Yes.
If at all the TBAs will be forbidden to carry deliveries, then I think the hospitals will be overwhelmed. I will probably not be able to handle it.
Female circumcision and maternal death is the worst in our hospital, because like me, for this month, not this month, last month, I did 3 defibrillations. That is distracting the FGM, whereby a mother comes in, she wants to deliver. Whenever you want to do the VE, that's the examination of the vaginal, and check if the cervix is open or not. To enter is even difficult because you cannot go with one finger, you have to go with 2 fingers, and to check if the cervix is open. So by the time you see it's only one finger which goes on, you need a space. So that's why we have to cut short. And the percentage there, the circumcision is over 90%.
The practice of female genital mutilation is very, very highly in the Maasai ethnic group, to about 99%. And in that case now, when a woman is mutilated, there is that scar which happens, whereby during delivery it becomes very difficult because there is no elasticity, and therefore it causes a lot of problems, rupturing, etc., and overbleeding. To avoid that, when a Maasai woman is pregnant, from day one, there's always a traditional birth attendant who is supposed to be behind to make sure that the nourishment is down.
Ambayo wanaanza kujifungua. Wamasai wanasema usile chakula nyingi au kuna dawa au kumtapika. Ndio.
And if you happen to see a baby who has been delivered at a traditional birth attendant, it is so small. If you see, you cannot, you might think that they are premature, but they are full babies who are born. They are told that when they eat much, when the baby becomes big, it might even stand in the stomach, and it becomes very difficult for her to deliver. And even when they are angry, the traditional birth attendants keeps on threatening them until now, the time when they deliver.
If the mother labors at home, the TBAs or untrained skill maybe wants to conduct this delivery, and then she gets a perineal tear where he cannot even manage to cut to separate the labia majoras so the baby can pass without any difficulties. So the only thing here now is the baby has to come with force. With the force, it causes perineal tear, and then it bleeds. By the time she bleeds, the mother can die because of bleeding. Yeah, we have so many cases where mother dies because of bleeding.
In pastoralist communities, sometimes they marry the women or the girls while they are very young. Some of them, they get married on the age of 14, 15.
However, young teenage girls are not physically developed enough, and the babies are often obstructed, posing a serious risk for both the mother and the baby's life. The young mother has an increased risk of tearing and hemorrhaging, but even if she survives the labor, she may be permanently damaged. The pressure from the baby's head can cut off the blood supply, causing the tissue to die. This gives rise to a fistula.
Obstetric fistula is simply the formation of a hole that connects the vaginal canal, in a layman's language, and the bladder, the urinary bladder, or the anus. Young women are mostly affected, and we are talking about their tissues are not quite developed to handle this kind of labor process. But otherwise, it can affect any woman.
When you are in labor, they believe that you should push. Immediately you feel pain, you are supposed to push so that the baby comes out. So you find that if a woman is in first stage of labor, the women will surround her and try to push, cooking sticks in the mouth to make her gag so that she can push. And then they think the baby should come out immediately, pain starts. So that is very, destructive to mothers. And most mothers die at home due to pressure. So that is a bad custom. And even for a pregnant woman, they are told don't eat eggs because your baby will have no hair. Just because the egg is, is slippery. They have the connotation that the baby also will have no hair when you are born. But the eggs are very nutritious for a pregnant woman. So if they don't eat eggs, then how is the baby going to grow?
Many local beliefs are positive and have developed as a way to protect mothers and their babies. Nonetheless, there are some that are dangerous. Other beliefs, such as no intercourse after giving birth, were beneficial, allowing the woman's body to recover between pregnancies and the baby to have a good start in life. However, in the last 20 years, this taboo of no intercourse has often been deadly with the arrival of HIV.
So he goes out to look for other women, and then there is the danger of bringing back sexually transmitted infections even later when the woman has already delivered.
It is not only the local cultural beliefs that cause problems, but also the hospital systems based on a colonial model. For example, the British colonies had strict routines which scared away the locals.
All these gadgets came with the colonizers. And when we built the hospitals, they were there to advise that you should put incubators here, separate the babies, take them to the nursery. So all these things are there in our institutions, but they are foreign to our community. Because people from the rural areas, they don't understand these things. Women used to come in labor ward and they are stripped to those straps until they give birth. So which was torture. I mean, it's a frightening environment for our women. So sometimes when we say only 40% come to deliver at the hospital, you know, there are these foreign things which I think also are, you know, a determining factor, whether the woman should deliver at the hospital or she should deliver in her own environment. I mean, women were not allowed to eat in labor, according to the British curriculum. But now we are saying in labor, they should eat, they should walk, they should have social support. So we are turning the clock round, and it takes time for people to realize that they should revert back. So in a way, we are confusing the community.
In many places, the systems are beginning to accommodate to the local needs.
What we have been saying, try and retain what is harmless. Try to change what you think is harmful. The beauty of community midwifery is that the midwife is a local of the community. She understands the culture, she understands the beliefs and their practices. So and on top of that, she's a learned person, she's a professional. So she can be able to balance between the two. Give professional work, yeah, yet respecting the cultures, but not compromising professionalism. The idea of addressing the family planning, or when do you intend to get the next pregnancy, is basically skipped in our setting.
In the community, they think that if you take contraceptives, you'll never have a child. You'll be barren. And you know, in Africa, barrenness is not entertained. Because if you have no child, nobody will respect you. It will be embarrassing. So it's stigmatized. So most of the people shun contraceptives because they think they will never have children. And whatever misfortune they see, if they bleed too much, some people have said, if you take these things, you'll be bleeding forever. So these are some of the myths that really shun women to take the family planning.
This country, legally, there is nothing like abortion. It's not legalized in this country. What would happen is that the mother who is not able to go and seek for a professional way of having it done will go behind the streets, will have an abortion, and this abortion, what will happen? Will have the infection and all what follows after that, whether it's going to be a perforated uterus and everything else. Then again, we are already increasing the maternal deaths now due to abortion.
If you are married, you cannot use a condom. Because if you use a condom, then you are promiscuous. So most of the men don't want the condom. Actually, some women have been divorced for suggesting to use condoms. Because then the man will say, where did you learn about these things?
I don't need to tell you the number of married women I've seen coming in for an abortion. 1, I got pregnant when I was not prepared. 2, I got pregnant, the pregnancy is not my husband. It's no big secret. The pregnancy is not my husband's, I need to get rid of it. All these issues will come in, and therefore that's the time I wish somebody talked to her about family planning, because this, which I would like to call a mistake, would not have taken place, and therefore the next mistake would not have taken place. Yeah.
And most of the men in the African setup, they will use the condoms for other partners. If they want to go out, they will use the condom there. But when they come in the house, there is no discussion about the condom. It should not be on the agenda.
What I found when I go to the developed countries, that even schoolgirls have access to family planning. That is not the case here. And it's because there is a struggle between morality vis-a-vis, sexuality and all that. So what happens is that majority of these girls will get pregnant, and the only option they have is abortion. And that's why if you manage to get to some of our very populated wards in the gynae wards, what you find is that majority of the people admitted in those wards are young girls, teenage girls who have come there not to have an abortion done, but for management of complications of abortion. I would say quite a number of them die. They do. They do. That one is a straightforward answer, yes, they do die because of illegal abortions.
So, what have we seen? A lot of goodwill, engaged midwives, mothers that care seriously about their health and the health of their babies. Yet, despite this engagement, they are in a system with failing infrastructure and gender imbalance that need to be changed. Across Africa, people and governments are working to improve this. However, there is still a long way to go.
The chances of reaching the Millennium Development Goals are there if we rethink and prioritize.
Yeah, the Millennium Goals, if you ask me, we are on the right track. But we are on the right track. So far, so good. The policies are there. We have strategies are there now. But you know, policies can be there, standards can be there, guidance can be there, but we are looking forward to putting all that into action because that's what interplays to reducing maternal mortality.
There could be a system, but if there is no resources, there are no resources, then implementation of whatever is needed is quite difficult.
Almost all causes of maternal mortalities are related to the policies that our governments do make. And they're also related to the value to which they accord to life. It is all about value for humanity and value for life in every policy that is made.
If we do not strategize as midwives, we do not develop strategic plans so that we have a direction, then it is very difficult because somehow midwives and midwifery in general has been like operating on a routine basis. But now I think the challenge is for leaders or managers in midwifery to be able to say what are the challenges and which strategic directions should we take, because without that you will not know where you are going and maybe you will not even know if you are reaching there or not reaching there.
It is not true that our governments are lacking these resources. It's not true that the governments lack ability to access these healthcare services to the mothers who need them. It's just lack of value for the life that is being lost. Because if governments decide that now we want to consider life, want to ensure that no life is being lost, let's ensure human resource is available, definitely to do that. But whatever is happening is just because of lack of value for human life and humanity.
What is clear is that Africa is unlikely to reach the Millennium Development Goal target of cutting maternal mortality drastically. But the process has started. Thanks to the intervention of the Selela clinic staff, Narkimunyaki was referred early to Mtoambu. On the 7th of November 2009, Narkimunyaki gave birth to twins, a boy and a girl. Dr. Felix Sanka attended the birth. The family has returned home and all are doing well. The rains have finally come, but for a large family with no livestock, the future is very uncertain.